I want to tell you something that I have repeated in my clinical practice more times than I can count. And each time I say it, I watch something shift in the person sitting across from me. Here it is. The heart does not fail suddenly. It does not give up all at once. It communicates. It sends signals, sometimes quiet, sometimes insistent, for months, sometimes years, before the situation becomes a crisis. And the tragedy I witness over and over again is that those signals were there. The patient noticed them. They mentioned them to someone. Maybe they even mentioned them to a doctor, and the answer they received was, "You are getting older. You are out of shape. You are under stress." And so the signals went unheard, and the heart kept losing ground. Welcome, my friends. I am Dr. Usaid, and in more than 30 years of practicing medicine, heart disease has been one of the conditions that fills me with the most urgency. Because it remains the leading cause of death globally, because so much of it is preventable, and because the window between early warning signs and irreversible damage is wide enough to drive meaningful change through, if only people knew what to look for. Today, we are going to go through 10 signs that your heart may be struggling, and we are going to understand each one from the inside out. Not just what it feels like, but what is physiologically happening in your body when it appears. Because when you understand the mechanism, the sign stops being abstract. It becomes a message you can read, and a message you can act on. Before we go through the signs, I need to give you a foundation. Because without it, the signs will not fully make sense, and I refuse to leave you with a list of symptoms and no understanding of why they exist. How your heart works, the foundation that makes everything else clear. Your heart is a pump. It is the most reliable pump ever engineered, beating approximately 100,000 times per day, every day, from before you were born until the moment you die, without ever stopping for maintenance, without ever asking for a break. And like any pump, its job is to move fluid through a closed circuit. In this case, that fluid is your blood, and the circuit is your entire body. The heart has 4 chambers. On the right side, the right atrium and the right ventricle. On the left side, the left atrium and the left ventricle. Here is the sequence of events with every heartbeat. Deoxygenated blood returns from the body through the venous system into the right atrium. It flows through a valve into the right ventricle, which pumps it to the lungs. In the lungs, carbon dioxide is exchanged for oxygen. Now, oxygen-rich blood returns to the left atrium, flows through another valve into the left ventricle, the most powerful chamber with the thickest walls, which then contracts and drives the blood out through the aorta and into the entire body. Now here is something important that most people do not realize. The left and right sides of the heart face very different workloads. The left ventricle pumps against the full resistance of the systemic circulation, a pressure of approximately 120 millimeters of mercury at systole. That is the number in your blood pressure reading. The right ventricle pumps against the much lower pressure of the pulmonary circulation, approximately 25 millimeters of mercury, a mere fraction. Which is why the left ventricle has a far thicker muscle wall, and why it is almost always the first side to show signs of strain. When either side of the heart begins to fail, meaning it can no longer pump efficiently and fully empty with each beat, blood begins to back up behind it. Left-sided failure backs up into the lungs. Right-sided failure backs up into the body, the legs, the abdomen, the venous system. And the signs and symptoms of heart failure are essentially the visible manifestations of where that backup fluid is accumulating. Once you understand that, every sign on this list will make immediate, intuitive sense. Also critical to understand, heart failure is not a heart attack. A heart attack, Myocardial infarction is an acute event caused by a blocked coronary artery that kills heart muscle cells within minutes. It is a sudden catastrophe. Chronic heart failure, CHF, is a slow, progressive erosion of the heart's pumping capacity, unfolding over months and years, driven by multiple converging factors. Today we are talking about the latter, the slow drift, the one that gives you time, if you listen. Sign number 1, shortness of breath with activities that never used to wind you. This is the most common early sign of heart failure, and it is also the most consistently dismissed. Because when a 58-year-old gets winded climbing a flight of stairs, the most available explanation is, "I am out of shape, I am older, everyone my age is the same." And that normalization of a genuinely abnormal symptom is one of the most dangerous things I encounter in clinical practice. Here is what is actually happening. When the left ventricle begins to weaken, whether from years of high blood pressure forcing it to work against excessive resistance, from the scarring left behind by a prior heart attack, or from the metabolic damage of chronic insulin resistance, it can no longer empty completely with each beat. Blood begins to pool in the left ventricle. And because the left atrium is draining into a chamber that is not fully emptying, it backs up too. And behind the left atrium is the pulmonary circulation, the network of vessels running through your lungs. As pressure builds in the pulmonary vessels, fluid begins to leak through the capillary walls into the lung tissue itself, a condition called pulmonary edema. Your lungs, which should be filled with nothing but air, are now partially filled with fluid. And gas exchange, the transfer of oxygen into your bloodstream and carbon dioxide out, becomes progressively impaired. The result? Your blood oxygen saturation drops with even modest exertion. Your body senses the deficit and drives the respiratory rate up, forcing you to breathe faster and harder to compensate. You feel out of breath, not because you are unfit, but because your left heart is failing to clear the pulmonary circuit. The distinction worth internalizing is this. Normal breathlessness comes on with genuinely intense effort and resolves quickly at rest. Heart failure breathlessness appears with activities that were previously effortless, worsens with even mild exertion, and may linger. If you have noticed a progressive decrease in what you can do without getting winded over the past 6 to 12 months, that trajectory matters more than any single episode. Sign number 2. Persistent fatigue and weakness that rest does not fix. Tiredness is so universal in modern life that it has effectively been normalized out of medical significance. Everyone is tired. Work is demanding, sleep is poor, screens steal the night. And so, when a patient tells me they are exhausted, deeply, persistently exhausted, the temptation, even for physicians, is to attribute it to lifestyle and move on. But there is a quality to heart failure fatigue that is distinct, once you know what to look for. It does not respond to sleep. It is present on days when the person has rested well, and it is accompanied by a physical heaviness, a weakness in the muscles, that goes beyond what fatigue alone explains. That quality comes from reduced cardiac output. When the left ventricle cannot pump sufficient blood to meet the body's demands, every tissue and organ receives less than its required oxygen delivery. Skeletal muscle, which depends on aerobic metabolism, the combustion of glucose and fat in the presence of oxygen to generate ATP, is forced to shift toward less efficient anaerobic pathways. Energy production drops, lactic acid accumulates, muscles fatigue faster, recover slower, and feel heavy even at rest. The body is essentially running on a reduced power supply, and unlike laptop fatigue from a low battery that can be recharged with a night's sleep, this fatigue returns with every morning, because the underlying cardiac insufficiency has not changed. Sign number 3. Rapid or irregular heartbeat. When the heart begins to fail as a pump, the body does something logical and understandable. It tries to compensate. One of the first compensatory mechanisms is an increase in heart rate. If each beat is delivering less blood per stroke, the body reasons, correctly in the short term, that beating more frequently will maintain overall cardiac output. The sympathetic nervous system activates. Norepinephrine is released. The heart speeds up. The problem is that this compensation carries its own cost. At high heart rates, the time available for the ventricle to fill between beats, diastole, is shortened. A heart beating at 100 beats per minute has almost no time to relax and fill properly before the next contraction is demanded. So the very compensation meant to maintain output actually begins to reduce the volume of blood ejected with each beat, what cardiologists call stroke volume, and the ejection fraction, the percentage of blood in the ventricle that is actually pumped out with each contraction, declines further. The body is running faster to stay in place and falling behind. Irregular heartbeat, palpitations, the sensation of a skipped beat or a sudden flutter, is a related but distinct phenomenon. Chronic pressure and volume overload in the failing heart stretches and distorts the electrical architecture of the cardiac chambers, making them susceptible to arrhythmias. Atrial fibrillation, the most common sustained cardiac arrhythmia, is both a cause and a consequence of heart failure, and it dramatically worsens the efficiency of the pump. A heart in atrial fibrillation loses the coordinated atrial contraction that fills the ventricle before its own beat, reducing cardiac output by as much as 20 to 30%, independently of any other factor. Sign number 4. Persistent cough or wheeze, especially when lying down. A cough that will not go away. Especially one that appeared without an obvious respiratory illness, without a new medication, and without allergies, is a symptom that cardiologists take seriously, and that most people dismiss entirely. Because coughing, in the popular imagination, is a lung problem, a chest cold, something that will pass. The cardiac cough tells a very different story. As pulmonary edema progresses, fluid accumulating in the lung tissue from left-sided heart failure, it eventually reaches the airways themselves. Fluid seeping into bronchioles and bronchi triggers the cough reflex in exactly the same way that a physical irritant would. The body is attempting to clear the airways of something that keeps coming back because the source is not in the lungs. It is in the failing pump behind them. The cough is productive in some cases, generating frothy sputum, sometimes pink-tinged from microscopic capillary bleeding caused by chronic elevated pulmonary pressure. This particular finding, pink frothy sputum with a cough, in the context of any of the other signs we are discussing, is an urgent clinical signal. A wheeze, the high-pitched sound of air moving through narrowed or partially fluid-filled airways, can also occur. Some patients are initially misdiagnosed with late-onset asthma. The clinical term is cardiac asthma, and while it shares some surface features with true asthma, the treatment is profoundly different. Bronchodilators will not resolve a wheeze caused by pulmonary edema. Addressing the underlying cardiac insufficiency will. Sign number 5. Sudden, unexplained weight gain over a few days. This is the sign that, when patients understand its mechanism, tends to produce the most visible reaction of recognition. Because so many people have experienced unexplained weight fluctuations that they attributed to water retention, stress, or dietary variation, without ever considering that the kidneys might be generating that fluid retention as a response to a signal from a struggling heart. Here is what happens. When the left ventricle begins to fail and cardiac output drops, the kidneys, which rely on adequate perfusion pressure and blood flow to perform their work, receive less than their required blood supply. The kidney has no way of distinguishing between true dehydration and reduced cardiac output. It only knows one thing: it is not receiving the blood flow it expects, and it responds to that signal the same way it would respond to dehydration, by activating the renin-angiotensin-aldosterone system, a powerful hormonal cascade that drives sodium and water retention. The kidney retains fluid in an attempt to increase the circulating blood volume and restore the perfusion it senses is missing. But since the problem is not dehydration, but a pump failure, this compensatory fluid retention does not fix anything. It simply adds to the fluid burden on an already overloaded circulatory system. The result is measurable. Patients can gain 2, 3, 4 pounds in 48 to 72 hours. Not from food, not from muscle, from fluid accumulating in tissues throughout the body. Monitoring your weight consistently, at the same time each morning before eating, is one of the simplest early detection tools available for this process. A gain of more than 2 pounds in 2 days without dietary explanation is worth a conversation with your physician. Sign number 6. Swollen ankles, feet, and legs. Edema. This is the sign most commonly associated with heart failure in the public mind. And appropriately so, because it is visible, it is uncomfortable, and it is a reliable marker of disease progression. But the physiological story behind it is more nuanced than most people realize. Peripheral edema, swelling of the lower extremities, is primarily a sign of right-sided heart failure. When the right ventricle cannot effectively empty and pump blood to the lungs, venous pressure rises throughout the systemic venous system, the vast network of veins returning blood to the heart from the body. Elevated venous pressure pushes fluid out of the capillaries and into the surrounding interstitial tissue. Gravity directs it downward, into the ankles, feet, and calves first, then progressively higher up the legs as the failure advances. Now here is the sequence most people do not know. Right-sided failure is usually secondary to left-sided failure. Left failure backs fluid into the lungs. Over time, that fluid in the lungs increases the resistance the right ventricle must pump against, a condition called pulmonary hypertension. The right ventricle, which evolved to pump against relatively low pulmonary pressures, is now pumping against pathologically elevated resistance. Eventually, it too begins to fail. And that is when the fluid that was previously confined to the lungs begins to appear in the legs and body. Clinical pitting edema, where a fingertip pressed into the swollen tissue leaves an indentation that persists for several seconds, is significant. It means the fluid accumulation has reached a threshold that the lymphatic system can no longer compensate for. If you notice that your shoes feel tight by late afternoon, that your sock lines leave deep marks in your ankles, or that your lower legs feel heavy and taut, please do not dismiss it as poor circulation or heat. Sign number 7. Nocturia. Waking multiple times at night to urinate. Waking once at night to urinate is common, particularly in adults over 50, and is often attributed to prostate issues in men or bladder sensitivity in women. Waking 2, 3, 4 times is frequently normalized as a fact of aging. But nocturia, frequent nighttime urination, can be one of the most revealing signs of advancing heart failure. And it operates through a mechanism that is both elegant and clinically important. During the day, in the upright position, gravity works against venous return from the lower body. Fluid pools in the legs, in the ankles, in the dependent tissues. The heart receives less venous return, the kidneys are relatively underperfused, and fluid accumulates peripherally rather than being excreted. Then you lie down. Gravity is neutralized. That pooled fluid from the lower body flows back into the central venous circulation, suddenly and substantially. Blood volume increases. The heart, already struggling, is suddenly presented with a much larger preload. More blood returning to the right side, demanding to be pumped. The kidneys, now suddenly well perfused after hours of relative underperfusion, respond to the increased renal blood flow by producing urine at a high rate. The result? You wake to urinate, return to bed, the cycle repeats. Each episode represents your kidneys finally getting the blood flow they need, only because you removed gravity from the equation. In isolation, nocturia is not diagnostic of heart failure, but in combination with any of the other signs we are discussing, breathlessness, leg swelling, persistent fatigue, it becomes a meaningful piece of a pattern that deserves clinical investigation. Sign number 8. Orthopnea, difficulty breathing when you lie flat. Here is the sign I mentioned in my opening that is present in countless bedrooms around the world right now, completely unrecognized. The person who cannot sleep without 2 or 3 pillows. The person who finds themselves gradually migrating toward a recliner because they sleep better sitting up. The person who, if asked, will say, "I have just always been more comfortable that way." They have no idea they may be describing a classic clinical finding of advancing biventricular heart failure. Orthopnea is the medical term for breathlessness that occurs specifically when lying flat and resolves when sitting or standing upright. The mechanism is the same one we discussed with nocturia, but experienced acutely in real time. When you lie down, the fluid that has pooled in your legs and peripheral tissues redistributes back into the central circulation. In a healthy heart, this additional fluid volume is handled without difficulty. In a failing heart with already elevated pulmonary pressures, this sudden increase in venous return overwhelms the left ventricle's capacity to clear it, and pulmonary edema worsens immediately. Fluid floods back into the lung tissue. Oxygen exchange deteriorates. The person wakes gasping, or finds they cannot comfortably lie flat at all. The clinical severity is sometimes graded by the number of pillows a patient requires, a somewhat informal but practically useful measure. 1 pillow, mild. 2 pillows, moderate. 3 or more, or the inability to lie flat at all, severe. Clinicians also watch for paroxysmal nocturnal dyspnea, the patient who falls asleep relatively flat and is jolted awake 1 to 2 hours later, gasping and needing to sit up immediately, often described as a sensation of drowning. This is one of the more alarming presentations of advanced heart failure and should prompt urgent evaluation. Sign number 9. Inability to perform simple physical tasks, stairs, groceries, walking. There is a trajectory to functional decline in heart failure that I want you to be able to recognize, both in yourself and in the people you love. It does not begin with an inability to climb stairs. It begins with an acceptance of a lower and lower threshold of what counts as normal activity. The person who used to walk a mile now walks 2 blocks. The person who used to garden for an hour now manages 15 minutes. The person who used to climb stairs without thinking now plans routes that avoid them. And at each step of that decline, there is a rationalization. I am older. It is hot today. I did not sleep well. By the time a patient cannot carry groceries from the car or climb a single flight of stairs without stopping to rest, the cardiac output is significantly compromised. At this stage, both ventricles are typically involved. Left-sided failure reducing the oxygen delivery to skeletal muscle, and right-sided failure creating venous congestion that further impairs circulation and increases the metabolic cost of any physical effort. The muscles are oxygen-deprived and congested simultaneously. Even the act of standing up requires an effort that the cardiovascular system can barely support. The clinical classification used by cardiologists, the New York Heart Association Functional Classification, grades heart failure from Class 1, in which there are no limitations on ordinary physical activity, to Class 4, in which the patient is symptomatic at rest and cannot perform any physical activity without discomfort. Most people are at Class 2 or Class 3 before they seek evaluation, having normalized extraordinary limitations as ordinary aging. By then, the heart has typically lost a substantial portion of its functional reserve, which is why the earlier signs, the breathlessness with stairs, the fatigue that does not resolve, the nightly bathroom trips, matter so much. They are Class 1 and Class 2 signals. They are the moment of maximum leverage. Sign number 10. swollen abdomen, and abdominal discomfort. The 10th sign represents a more advanced stage of the disease, one that typically emerges after both sides of the heart are involved, and the venous congestion has extended beyond the lower extremities into the abdominal cavity. It is a sign that should inspire urgency, because by the time abdominal swelling appears from cardiac causes, the physiological burden on the heart and other organs is substantial. When right-sided failure is severe, venous pressure backs up through the inferior vena cava into the hepatic veins and then into the liver itself, causing hepatic congestion, which can manifest as right upper abdominal discomfort or a sense of fullness under the right rib cage. The congested liver becomes enlarged and tender. Liver enzymes may be elevated. Digestive function is impaired because the portal circulation, the venous system draining the intestines, is also under back pressure. Appetite decreases. Nausea can develop. The person feels full almost immediately when eating. As venous pressure in the abdominal circulation exceeds the threshold of capillary oncotic pressure, fluid leaks directly into the peritoneal cavity, the space between the abdominal organs and the abdominal wall. This is called ascites. The abdomen becomes visibly distended, taut, and uncomfortable. In severe cases, several liters of fluid can accumulate. This fluid further impairs respiratory mechanics by pushing upward on the diaphragm, worsening breathlessness. It impairs venous return, and it creates an environment of systemic inflammatory activation that accelerates the decline of every failing organ simultaneously. What is actually causing the heart to fail? The honest conversation. Understanding the signs is only half the picture. The other half, the half that gives you the power to act, is understanding the causes. Because if the signs tell you where you are, the causes tell you how you got there, and, more importantly, how you stop traveling further in that direction. The single most common cause of chronic heart failure is sustained high blood pressure, hypertension. When the left ventricle must pump against elevated systemic pressure day after day, year after year, it adapts by thickening its walls, a process called hypertrophic remodeling. Initially, this seems like a good thing, a stronger, thicker wall. But the thickened wall becomes stiff. It cannot relax and fill properly. The chamber loses its compliance. And eventually, even the thickened muscle is no longer enough to overcome the chronic overload, and it begins to dilate and weaken. This transition from compensated to decompensated heart failure is the moment the signs begin to appear. The second major cause is prior myocardial infarction, a heart attack that killed a portion of the heart muscle. That dead tissue is replaced by scar, which does not contract. Every scar on the left ventricle is a patch of wall that is permanently absent from the pump's workforce. But here is the cause I want you to pay the closest attention to, because it is the one most within your control, and the one most consistently underemphasized by mainstream medicine. Insulin resistance, type 2 diabetes, and metabolic obesity. This cluster is now the third leading cause of chronic heart failure, and it drives the first two as well. Insulin resistance causes hypertension through sodium retention, endothelial dysfunction, and sympathetic nervous system activation. Insulin resistance causes atherosclerosis, the plaque formation in coronary arteries that leads to myocardial infarctions. Chronic hyperglycemia generates advanced glycation end products that stiffen the myocardium and impair diastolic function. Elevated insulin drives cardiac fibrosis. The metabolically dysregulated heart is under assault from multiple directions simultaneously, and the damage accumulates for decades before the first sign appears. Other significant causes include smoking, which accelerates vascular disease and directly depresses myocardial function. Chronic heavy alcohol use, which is directly cardiotoxic. Heart valve disease, and obstructive sleep apnea, which generates repeated episodes of hypoxia and pressure surges that chronically stress the right ventricle. The common thread through almost all of them, with the exception of congenital valve defects, is that they are influenced by how we live, by what we eat, whether we move, how we sleep, and how we manage the metabolic and inflammatory state of our bodies. What you can actually do. Prevention that is real, not generic. I want to give you something specific here, not the tired, exercise more, eat less prescription that leaves people exactly where they started. Real prevention for heart failure requires addressing the actual mechanisms that drive it. The first and most powerful intervention is reversing insulin resistance. This is the metabolic root of so much cardiac pathology, and it is reversed primarily through dietary change. Specifically, a significant reduction in refined carbohydrates and sugar, which are the primary drivers of chronic hyperinsulinemia. Every meal that does not spike insulin is a meal that is not promoting the vascular inflammation, endothelial dysfunction, sodium retention, and myocardial fibrosis that ultimately lead to heart failure. This is not a temporary diet. It is the restoration of metabolic normalcy. Whole animal proteins, quality fats from olive oil, avocado, fatty fish, eggs, abundant leafy and cruciferous vegetables, elimination of seed oils, processed foods, sweetened beverages, and flour-based products. This is the food architecture that your cardiovascular system was designed to function within. The second intervention is movement. Not as punishment, not as calorie burning, but as a physiological necessity. Your cardiovascular system requires the mechanical stimulus of regular movement to maintain the tone and compliance of the vascular walls, to promote the release of nitric oxide from the endothelium, to support lymphatic circulation, and to preserve the cardiac muscle's conditioning. This does not require a gym membership. It requires consistent, frequent, low to moderate intensity movement throughout the day, walking, climbing stairs, carrying things, moving in the ways your body was designed to move, supplemented by periodic higher intensity effort to stimulate cardiovascular adaptation. The third intervention addresses inflammation, the invisible tide that silently damages every cardiovascular structure over decades. Omega-3 fatty acids from fatty fish or a quality fish oil supplement reduce inflammatory signaling throughout the cardiovascular system. Adequate vitamin D supports endothelial function and reduces hypertension risk. Addressing homocysteine, an amino acid that, when elevated, is an independent risk factor for vascular damage, through adequate B12, B6, and folate intake, or supplementation if the MTHFR genetic variant is present. These are not marginal adjustments. In the context of a cardiovascular system already managing elevated blood pressure or insulin resistance, they represent the difference between a fire that smolders and one that is being actively extinguished. And finally, the dimension that the medical world perpetually under-prioritizes: emotional and psychological health. Chronic stress is not merely an uncomfortable feeling. It is a sustained activation of the sympathetic nervous system and the HPA axis, generating persistently elevated cortisol and catecholamines that raise heart rate and blood pressure, promote inflammation, disrupt sleep, and chronically strain the cardiovascular system. The person who decides to become the author of their emotional life, not by pretending negative things do not happen, but by building genuine resilience, by choosing environments and relationships that support rather than deplete them, by practicing the disciplines of rest and reflection, that person is doing something genuinely protective for their heart, not metaphorically, biochemically. Closing. What the heart has been trying to tell you. My friends, I want to close with this. The heart is not dramatic. It does not announce its distress with fanfare. It whispers first. A little more breathlessness on the stairs, a little more fatigue by afternoon, a few extra bathroom trips at night, shoes that feel tight by evening. And then it speaks a little louder, and then louder still. And the people who hear it early are the ones who have given themselves the knowledge to recognize what the body is communicating. You now have that knowledge. You understand the difference between left-sided and right-sided failure. You understand why pulmonary edema makes you breathless, why the kidney retains fluid when cardiac output drops, why lying flat worsens breathing, why your legs swell by evening and your bladder wakes you at 2 in the morning. You understand that insulin resistance is at the root of much of this, and that it is reversible. You understand that the 10 signs we have walked through today are not destinations, they are signposts, and the earlier you see them, the earlier you can change direction. Now I want to hear from you in the comments. Which sign on this list surprised you the most? Which one are you going to pay more attention to in yourself or in someone you love? Be specific, because the specificity of your answer tells me what the community needs to explore next. And this community becomes stronger with every honest response shared. If this masterclass has genuinely moved something in your understanding today, and I believe it has, then I ask you to do one thing. Subscribe to this channel and activate the notification bell. Because the next video could be the one that prompts a conversation with a family member who has been ignoring something important for years. It could be the one that arrives in your feed on exactly the day you needed it. You deserve to be there for that. Take care of your heart, not out of fear, but out of deep respect for the organ that has kept you alive through every challenge, every night of poor sleep, every difficult meal, every stressful year. It has been working for you without ceasing, without complaint, since before you took your first breath. Today, begin working for it. I am Dr. Usaid. Until our next meeting, eat with intention, move with purpose, rest without guilt, and listen to what your body has been trying to tell you.